Unstable angina and non-ST elevation myocardial infarction. Etiology, Pathophysiology, and Pathology. An atheromatous plaque within a coronary artery reduces the blood flow to such an extent that there is ischemia at rest, unstable angina. The plaque may fissure or erode, exposing the dense lipid core. The lipid is very thrombogenic, causing platelets to clump on it. If the thrombus is not sufficient to occlude the artery, it reduces blood flow downstream and pieces of the thrombus may break off and pass downstream to lodge in small end vessels, causing non-ST elevation myocardial infarction, Fig. 38. Clinical presentation. Rapid onset of central chest pain at rest, unrelieved by glyceryl trinitrate, GTN. Pain may escalate, and occur with increasing frequency and severity, crescendo angina. Pain may radiate to jaw and arm. Severe breathlessness may reflect pulmonary edema due to transient impairment of left ventricular function. Physical signs. Often there are no abnormalities on examination, but other causes of chest pain may be excluded. Investigation. ECG. Often normal, but look for ST segment changes and T-wave inversion. T-wave inversion alone has no prognostic significance. Cardiac biomarkers. Cardiac catheterization. Differential diagnosis. After excluding ST segment elevation myocardial infarction, other diagnoses should be considered. These are the same as the differential diagnoses for ST segment elevation myocardial infarction. Treatment. The aim of treatment is to limit myocardial damage by pacifying the vulnerable plaque with medication. Patients who fall into high-risk groups undergo cardiac catheterization. Emergency. Aspirin, sublingual GTN followed by an infusion, beta blocker, low molecular weight heparin and a statin. Chronic obstructive pulmonary disease and peripheral vascular disease are not contraindications to beta blockers, and these groups benefit greatly from cardioselective beta blockers. Clopidogrel, with an initial loading dose. Glycoprotein IIB/3A antagonists are recommended for patients with unstable symptoms and a positive troponin assay. In hospital management, continue anti-anginals and antithrombotics. Patients who do not have elevated troponin are diagnosed with unstable angina and do not require urgent cardiac catheterization unless they fall into a high-risk group. Cardiac catheterization with a view to revascularization is indicated in high-risk groups. Positive troponin assay. Ongoing ischemic pain. ST segment changes with pain. Recurrent unstable angina. Ventricular arrhythmias. Long-term treatment. Patients admitted with unstable angina are treated medically, and if the pain settles they are assessed in the same way as patients with stable angina. Medications should be continued, and if the troponin is positive clopidogrel is continued for 1 year. Complications. Common. Recurrent angina. Myocardial infarction. Uncommon. Pulmonary edema. Ventricular arrhythmias. Prognosis. The risk of death or non-fatal myocardial infarction is 7% at 6 months with appropriate revascularization of high-risk cases.